We present a single-stage repair of a complex anterolateral radial and posterior root tears of the lateral meniscus with a concomitant multi-ligament knee reconstruction of the anterior cruciate ligament, medial collateral ligament, posterior oblique ligament, and anterolateral ligament in a young athlete. Disclosures for the senior author are listed. The patient is positioned supine under general anesthesia. Examination under anesthesia confirms preoperative findings. A well-padded high thigh tourniquet is applied. The limb is prepped and draped in a standard sterile fashion. A longitudinal incision is made starting over the vastus medialis oblique and extended 8 cm distal to the joint line. The sartorius fascia is incised to expose the pes azurinus and the distal superficial medial collateral ligament. The semitendinosus and gracilis tendons are harvested proximally with an open tendon harvester. The distal SMCL tibial attachment, which is 6 cm distal to the joint line, is prepared with 2 Q-fix anchors for graft fixation. Using the adductor tubercle as a landmark, the medial femoral epicondyle is identified, and the SMCL femoral attachment is localized 12.6 mm distal and 8.3 mm anterior. A guide pin is drilled through the SMCL remnant to exit anterolaterally. The POL femoral attachment lies approximately 11 mm proximal, slightly posterior to the SMCL site. A parallel guide pin is placed. Both femoral tunnels are over-reamed to 7 mm, and passing sutures are left in place. The POL tibial footprint is along the posterior medial tibial ridge adjacent to the semimembranosus insertion. Guide pin is drilled from posterior medial to anterolateral to exit 15 mm medial to Gerdy's tubercle. This tunnel is over-reamed to 7 mm, and passing sutures are placed. The harvested semitendinosus and gracilis are passed proximally beneath the sartorial fascia to the SMCL femoral tunnel. Each autograft is marked 3 cm proximal to the tunnel, whip stitched with number 2 non-absorbable sutures, and cut. Excess graft is reserved for the posterior oblique ligament. Through an anterior incision over the patellar tendon, a central third BTB autograft is harvested. The patellar bone plug measures 10 by 20 mm, and the tibial bone plug measures 10 by 25 mm. The patellar graft harvest site will be bone grafted and the tendon defect closed at the end of the case. Laterally, the iliotibial band is exposed. An inferior ITB strip measuring 8 by 1 cm is harvested, preserving its distal attachment at Gerdy's tubercle. The anatomic ALL tibial footprint is identified 1 cm distal to the joint line, midway between Gerdy's tubercle and the fibular head. A Q-fix anchor secures the ITB graft to recreate the ALL tibial attachment. Standard anteromedial and anterolateral portals are established for diagnostic arthroscopy. The ACL tear is visualized. The femoral footprint is debrided and identified approximately 2 mm posterior to the lateral intercondylar ridge, centered between the native anteromedial and posterolateral bundle insertions. With the knee hyperflexed to 120 degrees, a guide pin is advanced and reamed to a depth of 25 mm with a 10 mm reamer, maintaining a 2 mm posterior back wall. In the medial compartment, a ramp lesion at the posterior medial meniscocapsular junction is identified using probing and a modified Gilliquist view. The unstable ramp is repaired with all inside suture implants, reapproximating the capsule to the meniscal rim. In the lateral compartment, a posterior root tear of the lateral meniscus with concomitant high-grade radial tear is identified. This pattern may include displacement to the lateral gutter lateral to the popliteus tendon. If it is irreducible arthroscopically, a limited open retrieval is performed. The native tibial root footprint on the posterolateral tibial plateau is decorticated to a bleeding bed with a ring tip curette or a curved shaver. A meniscal root guide is centered on the footprint. 2 transtibial tunnels are drilled from just distal to Gerdy's tubercle into the footprint. The first tunnel is posterior, the second tunnel is about 5 mm anterior using an offset guide. Using a first pass mini device, 2 vertical mattress ultratape sutures are passed through the posterior root tear. A passing wire directs the posterior suture to the posterior tunnel and the anterior suture to the anterior tunnel. The sutures are shuttled and tensioned to reduce the root to the prepared bed and are secured over a cortical button on the anterolateral tibia. Attention then turns to the mid-body radial tear. Peripheral inside-out vertical mattress sutures re-establish the meniscocapsular contour. Horizontal ripstop sutures span the defect to resist cut-through and restore circumferential fiber continuity. Final probing confirms a stable repair with restoration of hoop stresses. Next, the ACL tibial tunnel guide pin is drilled in line with the anterior horn of the lateral meniscus and over-reamed with a 10 mm reamer. The BTP graft is passed up the tibial tunnel and into the femoral tunnel. It is fixed with a 7 by 20 mm titanium interference screw. With the knee in full extension, the ACL graft is secured in the tibial tunnel with a 9 by 20 mm titanium interference screw. At 20 degrees of flexion, the superficial medial collateral ligament and the posterior oblique ligament autografts are passed into the femoral tunnel and fixed with a 7 by 20 mm bioabsorbable screw. The POL is then secured in its tibial tunnel in full extension with a 7 by 20 mm bioabsorbable screw. The proximal SMCL tibial attachment is recreated 15 mm distal to the joint line using a Q-fix anchor to secure the semitendinosus and gracilis autografts. The ALL graft is fixed at its femoral attachment with a Q-fix anchor just posterior to the lateral femoral epicondyle at 20 degrees of flexion in neutral rotation. Knee stability is assessed and the deep and superficial closure is performed.